for the opportunity to come. Thank you so much for the opportunity to come and speak with many of you. I was really impressed by the range of organisations and communities that you represent, because you know this is all of our tasks that's in front of us around mental health reform, and I just note you use the word excitement, so hopefully I can live up to that. Can I begin by acknowledging the traditional owners of the lands in which I join today's call? For me, that's the Wurundjeri people of the Kulin Nations, and pay my respects to their elders, past, present and future. I would also like to acknowledge all people with lived experience of trauma, neurodiversity, mental ill health and substance use or addiction, and their families, carers and supporters. This recognition extends to the clinical and non-clinical workforces that support people with lived experience. So I understand from the brief that came across Bronwyn that you were keen to hear the next steps and timelines with the implementation of the Royal Commission recommendations, including some of the more recent work around the regional boards, the area, local services and value of lived experience. So let me speak to some of those points. And as I said, I'll flick through the slides and, you know, hopefully leave plenty of time for conversation. So really also keen, you know, to where I can hopefully highlight areas of where you can learn more about the opportunities for this group and members to be involved in our work and how you can contribute to the broader mental health reform. And I'll address what I believe are some of the challenges ahead for us with the reform. So, you know, I think kind of the risk of stating the obvious, you know, this is the Royal Commission report was released just on 6 months ago. And I think in many ways was really a kind of line in the sand moment for Victoria, and indeed the mental health and wellbeing for Victorians. So, you know, this scale of change is not easy, and I think in these uncertain times, sometimes harder and sometimes even more pressing. But it will take a lot of work, and I think frankly if it was going to be easy we wouldn't have needed a Royal Commission to lay this out for us. But a really exciting opportunity ahead of us, and at the department we're really keen to hold on to that momentum that's been created by the Royal Commission, and you know, reinforced by the government's commitment for full implementation. So my role is as the kind of Senior Executive Director of Mental Health and Wellbeing Transformation, which is a new portfolio, part of a new division of mental health and wellbeing. I spent most of last year leading a small team working on the implementation of the interim report recommendations as part of Mental Health Reform Victoria, and we've now brought the kind of reform arm together with the operating systems management teams, and just kind of come out the tail end of quite a significant organisational change, because we recognise too that we've got to disrupt ourselves internally in terms of, you know, the transformation that needs to begin. And part of that, I think, has, you know, been really important to build a new operating model, one that embeds lived experience at senior levels within the organisation. We've just gone to market for an executive director of lived experience. We've got director roles for lived experience and lived experience advisory. Hubs being embedded in the division, which is really exciting, but I'll speak a little bit about that through the course of the presentation. If I just go to this slide, I think this is there are 65 recommendations in the final report. I expect you've all read all the 3,000 pages. There's another 9 recommendations in the interim report. You know, 74 recommendations. If you counted all the subcomponents, I think someone said to me it adds up to about 240 different initiatives. But the Commission said don't look at them in isolation from each other. This is a systems reform, and each of those recommendations do have interdependencies, will inform the sequencing of other recommendations. So what you've got on this slide is really how we're starting to aggregate up the different themes and the major kind of work streams of the Royal Commission. And you may have seen this reflected in some of the communications from the budget this year, but we're effectively focusing across the recommendations around 7 key areas of reform, of which, you know, I think one of the core pieces is about putting people at the centre of mental health reform and design, moving to a system that offers people a full range of supports in their communities and close to their families. This year's budget, delivered a record investment of $3.8 billion, which I think, most excitingly included more than $1.5 billion for community-based care. And community-based care, a system, is really what needs to be rebuilt if we're going to realise the vision of the Commission. We're tasked with a range of recommendations. As such, we're designed to address both critical demand and provide urgent relief in the system, really, which addresses, decades of underfunding and underinvestment, but at the same time try to begin to lay the foundations for future reform and more contemporary services that fit the needs of our communities. Last week we had marked a really important implementation milestone, which was the introduction of enabling legislation to the Victorian Parliament to establish the Victorian Collaborative Centre for Mental Health and Wellbeing. This is really exciting. The legislation just, gives it, this is a long path, but to stand up the Collaborative Centre, but this first step is about giving legal form and structure to the centre. But I think importantly, it will connect lived experience leadership, innovative service delivery, and cutting edge mental health reform. And I think the Collaborative Centre Bill, and I'd urge you all to read it if you're interested in a second reading speech and legislation. I think it signals a really united approach, which moves us from an us and them kind of service sector to all of us together, a genuine collaboration at the heart of a mental health and wellbeing service. So I think aligned with your statement of intent, I do think organisations like yourselves and this group are really key partners in achieving sustainable outcomes and instrumental in terms of the leadership required ahead of us. I do believe to achieve the consumer-centred outcomes of the reform, we're going to need really strong leadership. And as the Commission itself noted, the more complex the reform process, the more important leadership is. So really value many of you on this call today, the leadership that you play. And we've seen this leadership across the sector really since the beginning of the implementation. For example, with the Mental Health and Wellbeing Act, the Workforce Strategy and the Local Services Initiative, we've received hundreds of submissions, conducted extensive consultation with a wide variety of people and organisations, including individuals with lived experience, consumers, carers, First Nation representatives, clinicians, service providers, academics, and peak bodies, just to name a few. We've seen that leadership evident with lived experience, co-producing residential services over the last 12 months, the design of 4 new child and youth hope services. But that does also remain both an opportunity and challenge, because we do know that co-production may not always be suitable or appropriate, and that where true co-production is not possible, partnering with lived experience needs to occur across as many phases as possible. I think we're also learning through this process so far as to how we build our engagement, activity and participation mechanisms, very mindful of those power imbalances that exist and permeate the system in many ways if we are going to realise the value of the full potential of lived experience expertise. As I mentioned before, we've created a lived experience branch and a division. We're also standing up a dedicated unit within one of the teams that I manage around human-centred design to really support those co-production mechanisms becoming more the norm rather than the exception in terms of the way in which we're going to be delivering services. A little bit about the regional mental health and wellbeing boards, because that was something that came up, and the interconnections with the areas and locals, and I'll just go on to the new slide. As you're aware, the Royal Commission recommended creating 8 regional boards around 8 kind of new established boundaries. I use the word boundaries somewhat reluctantly, because in the future system, boundaries will no longer be about access to service and service eligibility. They will be used for the purposes of planning and needs assessment. So we'll be moving the system from one of which, is, am I eligible for that service? I have to tell my story again, to how can I help, and how can you best and fastest access the service and the supports that you need. As a precursor to the establishment of these boards, the Commission recommended the establishment of 8 interim regional bodies. The interim bodies are really the first step in a decentralised governance reform, and as mapped out on this slide, they really form a 5-year plan to transition functions from the department to the regional boards.
Hello, how are you?
Hi.
I'm good. Let me just get out of that.
By the end
Sorry
of
about that. I
2026, I think someone may not have their on mute.
Yeah, just a reminder, everyone, if you could just pop yourself on mute, thanks.
Great. So the chairs, so the recruitment of the chairs is the first step for these interim advisory bodies. They are the precursor to the boards. The boards will be enabled as part of the legislation, the new Mental Health and Wellbeing Act. But the process of establishing these regional bodies has already commenced. We've got an expression of interest now out. So if any of you are interested in expressing interest for the role of the chairs of these advisory bodies, you can certainly participate. Please participate in that process. But our first step is to appoint the chairs, and it will be then to work with each of the chairs to recruit the remaining members to each body. We are anticipating that each body will have about 5 members and will include a person with lived experience as a consumer and a person with lived experience as a family member, carer or supporter. So the chairs will also support the division in the coming 12 to 18 months in particular, to engage with their local communities, their local networks, to determine the final alignment of the 8 boundaries or regions, but also to inform other critical recommendations such as statewide services and capital plans and regional service and capital plans by the end of 2023. So a little bit about the network system of local and area services. So as I mentioned at the outset, this is a system which will be centred around community-based services. The new system recommended by the Commission will be comprised of 6 levels. The Royal Commission's focus will be on, or most of our implementation focus is on, I guess, those bottom 3 levels. And I think, no, sorry, the levels aren't on this slide, but if you might remember in the report, if any of you seen previous reports, it's kind of 6-tier level, of which, the kind of front line is the community and families, networks and neighbourhoods and primary healthcare and primary kind of platforms, then into the kind of local area mental health services, the tertiary system and the state specialist services. So most of our focus is very much around those last 3, the new local services platform that needs to be built, the enhancements and expansion of capacity of the area mental health services, and moving to new models to support the statewide specialist services, all which need to be networked and need to speak to each other. So the Commission recommended 50 to 60 new local services for adults and older adults, in addition to dedicated local services for infants, children and families, and to work in collaboration with the Commonwealth and with Headspace to really enhance that platform and the integration of that platform with other tiers of the service for young people. So area level services will continue to provide tertiary and high intensity services for people with acute or complex needs. There will be approximately 22 area services for adults and older adults, and 13, I think it's actually 14, sorry, 14 infant and children, for infants, children and young people. For infants, children and young people, area-based services will be streamed into those aged 0 to 11 and to those aged 12 to 25. And at the most specialised level of care, the Commission has recommended expansion to Victoria's statewide services. But in expanding the statewide services, it is also said that these services effectively have to drop down more locally, that these services have to be much more accessible on a localised basis and delivered in such a way that minimises the need for people to travel to access services. a bit about the area, the transformation plans of the area mental health and wellbeing services. So one of the centerpieces really is about the transformation of the area mental health and wellbeing services, both structurally and in support and service models. Large-scale reform was recommended to effectively get more people in, to support more people in the services they need and to provide more therapy. So all of our area services are now recruiting a significant number of clinicians and support staff to service what is almost effectively a 40% expansion in capacity of services over the next 4 years. These services, the health services, will be restructured in 2 streams to ensure that access to treatment is accessible and equitable across all age groups, and that the treatment and care and support always has the right developmental focus. As I said, we've got the streams of 0 to 25, and adults and older adults spans 26 years and older. And as you would imagine, you would understand deeply, that requires some structural change and shifts across the health services. It will also ensure that age boundaries are consistent across the state, with flexibility to ensure consumer choice always comes first. Each of these services will move to operating with extended hours and respond to crisis calls from anyone in the community 24 hours a day, 7 days a week. And importantly, local and area-based services will be formally networked to really promote and support staged care, whether that's delivering integrated clinical and wellbeing services through partnerships with NGO wellbeing providers, or through the provision of primary and secondary consultation on liaison services. And I want to say a little bit about the health services partnerships, which many of you would have been engaged in or servicing, and how do these fit in with the mental health reforms. So yes, July this year, the health services partnerships were more formalised as a kind of enduring element of the Victorian health system, and they've effectively replaced the health service clusters that emerged during the pandemic that brought together health services within regions to tackle common challenges. The work of the clusters really did highlight how much more resilient our system is when health services collaborate and work together. And I think it's really been an enduring feature of the pandemic as to how we now build on those foundations. So we are working around thinking deeply about how the health services partners can work together with the interim regional bodies as we stand these up to support the communities to achieve the highest attainable standards of mental health and wellbeing through joint planning, integration, and focus on outcomes. So with the health services partnerships will focus on moving the health system from competition to collaboration by requiring the health services to work together. And indeed, I think of the 4 initial priorities for the health services partnerships, mental health reform alongside obviously ongoing COVID response, the Better at Home initiative, elective surgery and emergency care access, other priorities for the health services program. So we're really excited about what is possible ahead of us with those new formalised collaboration mechanisms on the ground. A little bit about the local adult and older adult mental health and wellbeing services, because this has really been described, and you may have heard the Minister use the words, a flagship reform coming from the Royal Commission. So the Royal Commission has recommended, as I said, up to 50 to 60 of these services statewide. That's what they've determined is needed to reach population coverage. I think on average, 1 every 100,000 population. And this year's budget gave the first tranche of investment to establish 20 of these. So this is a new level of service, and the intent here is with this new level of services, it will create a very broad front door by which people can access the mental health service. It will have core functions including initial support discussion, comprehensive assessment, clinical treatment and structured psychological therapies, wellbeing supports, education and peer support, and care planning and care coordination. So the first 6 priorities were announced as part of budget, and these will be opened by the end of 2022. They are in Benalla, Brimbank, Frankston, Greater Geelong, Latrobe Valley and Winchelsea, and we're engaging with the sector and the local communities as this work progresses. So I think at the beginning of September, the department held a forum with the non-government sector to consult on the latest developments, including opportunities to be involved in the local services reforms. Through these sessions, we got a lot of great insights, which have really been applied and informed the commissioning framework, including things like how do these regional bodies align with the Commonwealth funded primary healthcare networks and the capability of regional body members, the intersections between mental health reforms and NDIS, for example, and how do you ensure cultural safety across the service delivery and careful statewide planning. I do hope, if it's not today, tomorrow, the release of the tender documents for those first 6 services will be released, and we're really excited to get to this stage. The next stage is part of the kind of commissioning approach and deciding the services, evaluating those, conducting the tender process will also be around following kind of co-design at the local communities with the preferred providers for these services. So these services is well underway, and they will come online at different times and through different arrangements depending on the population. So as I said, for infants, children aged 0 to 11, we will first establish 3 infant, child and family health and wellbeing hubs. The Commission recommended only 3 in the first iteration to kind of act as a bit of a prototype to understand what the demand and what the service model will be. And they're quite, age appropriately, very distinct and separate from a kind of mental health system. So how do you create a platform that is family friendly, is where the communities already connect to, and actually caters for both physical health and mental health, and has, is not a stigmatizing mental health front door to work through. And I think that's a really exciting part of the reform, which will move more towards in the coming months. For young people aged between 12 and 25, this is really around enhancing the support provided through the existing headspace network funded by the Commonwealth. And we know when we're working closely with the Commonwealth for what opportunities there are to enhance both the accessibility of the headspace platforms. We've also just released some funding into our local KIM services to deploy additional clinicianal workforce to do secondary consults with headspace, local headspace centres. And I think, and also to be co-located in the headspace locations. I think this is a great example of where we've had to respond to really a kind of at-risk cohort, how young COVID and its impact on young people, you would be feeling and seeing almost on a daily basis. And I think by providing this surge workforce from our KIM services, it's going to help fast track and build those collaboration on the local level with headspace as well. So work to establish the local services is progressing. As I said, the first 6 sites will be opened by the end of next year. And I'm almost at the end, so keen to open up for discussion. So just in kind of closing, as I said, this is a highlight of some of the early responding to some of the things you're keen to hear more about. I think probably what I haven't also spoken about is 2 other big pieces of work at the moment is the repeal of the existing legislation, Mental Health and Wellbeing Act. And there's been an expert advisory group and a kind of statewide consultation process run through Engage Victoria to assist with the drafting of and the repealing of that legislation and the drafting of the new legislation. This is really a big task and short timeframes. The Commission has said that government has to do this by the end of 2022. The other key piece here, which I haven't spoken about, and I might just finish on this reflection, is the workforce strategy. So we know without workforce, none of this is possible. And indeed, as you would be experiencing, workforce is almost a rate limiting factor to how we can roll out these reforms. The Commission said asked government to come up with a workforce strategy by the end of December 2021, which is not far away. And we've been advancing through some roundtables, Engage Victoria consultation, stand up of a workforce reference group to really advise government on how best we can pull together this strategy, which has to deal with both the short-term supply issues, the reality of well-being and fatigue issues in the sector at the moment, but also looks forward to those kind of structural changes and what's needed to support a workforce for the future. So really happy to kind of finish up there, and keen to kind of hear more about your reflections, your experience and feedback, and any questions if I can answer. Thank you. I might stop sharing my screen as well.
Thank you so much, Pam. It was really good to get that overview. And I think I know I can speak for myself to say that every time I do a consultation or attend a webinar or read a document about the reform, just another little bit clicks into place for me. So it's a big thing to get your head around. So thank you very much for sharing. Bronwyn, do you want to just, I've still got Pam's slides sharing. I'm not sure if that's from Pam's screen or Bronwyn's screen. Oh, there we go. Perfect. So we've had a few questions come up in the Slido chat. So I might start with those. But yeah, it'd be great to have some discussion. Sounds like some of the questions you might have answered along the way, but I'll just go through them. So one of the questions was, how will the regional boards and the local and area services integrate with the new federal mental health hubs? So the Head to Health services, which are also being established at the moment.
Yeah, great question, and I think great opportunity. I mean, there's a couple of really important chapters in the report which speak to both the collaboration and partnership that's needed between the Commonwealth and the state to really transform the system. It has called out the opportunity to look at how we bring together and some of these service models, and really around the principles of trying to reduce duplication, to reduce fragmentation, and try and improve make the system easy to navigate for consumers. So that's a point of discussion and deliberation with the Commonwealth at the moment. We've got the Head to Help. Pleasingly, the Head to Help clinics have been now extended until the 30th of June, which I think is next year, which is really critical. I have the great privilege of chairing that task force with Ruth Vine, and it's just been really impressive to see both how quickly the PHNs could stand those services up, how the providers have really built and iterated models of care, and just how much support they are providing to Victorians during a really difficult time. So I think not only do we have to look at how they converge with the locals, but also the new adult mental health hubs that the federal government have foreshadowed as well. So that's all in front of us, and let's see how we can go in terms of trying to drive a bit more of a partnership in that space.
And I can certainly, as a Head to Help provider, I can certainly speak to I think having a really good integrated model with a multidisciplinary model that's the wraparound care model has been really good, but it's also been really challenging having and I think a lot of people here in this meeting will be able to talk to the confusion that comes when there's a new pathway and a new thing, and we sort of I suppose we had a fairly well established sort of stepped care model in the East, and then the Head to Help model, which is actually delivered by the same providers as the stepped care model. I think it was quite confusing for a lot of people, including the providers, about which one is which and what is which. So I think it'll be there'll obviously be a really big sort of communications, for want of a better word, piece around these new services and what the entry points are. That balance of having something that's accessible but not having so many different entry points across the system that it gets confusing.
Yeah.
So the next question, I think you did answer this. I think you mentioned about that the tenders, the RFQ will come out this week. So the question was whether the local services will be competitively tendered and who will deliver them. Did you want to make any other comments or?
No, I think just simply, make sure you've registered on the department's website and keep refreshing. You'll find out more about that very shortly. And so yes, they are being competitively tendered, and I think once you're able to access that specification, much of that will become a lot clearer in terms of what the opportunities are.
Can I ask a off-the-cuff sneaky question around that? Do you know, it probably says in the documents, but are you able to say how, what period of funding that the new services will be? Like, are they going to be sort of 3-year contracts or ongoing?
I think I need to leave that for the tender documentation, just making sure it's not, I'm not quite sure whether it's actually, the law, it was planned to go out very shortly, so
okay,
that should be clear.
So the next question was, when will the Eastern region local services be commissioned?
Great.
Everyone wants to know.
Everyone wants to know. No, great question. You know, I think I can't answer that. We haven't gone through the site selections and the next tranches. But what I can say is, I think, you know, there's a recommendation 47 in the Commission's report really speaks to, I think, this moving the system to a much more kind of transparent and equitable planning of services and levels of services across each of the areas of Victoria. So the Commission has, you know, made a lot of comments and observations about the lack of planning across the system in the past, and how that has led to some regions being overserviced and some being underserviced and not necessarily meeting the needs of the local population. So one of the big tasks ahead is to develop a statewide service and capital plan. This must be developed by the end of 2022. And that will be the precursor to regional planning. So there will be then 8 regional plans, which the advisory boards will develop in consultation with the department and communities, which need to be completed by the end of 2023. So that's a longer question. I can't say specifically about the locals and when you might know when the Eastern Service, but you know, I think there's a really kind of important systematic kind of design piece that will happen in the back alongside that as well.
So there's 2 questions around workforce. One's a question and one's more of a statement, I think. So you touched on this, but with the current workforce shortages that we are all aware of within mental health and AOD, how would we meet a 40% plus expansion of workforce? And there's sort of a follow-up question / comment in regard to that surge workforce, that what we need more than a co-location of services within Headspace or other services is clearer and easier pathways into tertiary services.
Yeah. Thanks for those questions. A few reflections. I think the workforce strategy is interrogating deeply that question. You know, with current shortages, how do you meet the rapid expansion needs of the workforce? And you know, just even in the current context where we had borders closed, and you know, I think someone quoted to me recently that maybe 25 or 30% of the growth in the workforce has come from migration over the last 5 years in the mental health sector. And you know, when that's a major channel of workforce kind of closed or somewhat restricted, this is really problematic. So I think this is a problem that is not just unique to Victoria, it's for all jurisdictions. And I think that's something, that the workforce strategy will hopefully provide us with a few more ways forward in terms of that, but it's going to require a lot of out of the box thinking as well. On the surge workforce, absolutely agree with that comment. He's made that. What we need is more than a co-location of services within Headspace and services, clearer and easier pathways. Absolutely. One of the recommendations is that Victoria works with the Commonwealth and its local Headspace centres to actually provide a much clearer integration between Headspace and the local kind of KIMS services. So if you imagine, I mean, we're effectively trying to build out a 4th level, a broad front door for any age to walk through. And in time, that should be how you access a tertiary service or a specialist service, is through that broad front door. I think that's the intent of the locals, and it's what we'll do with the infant and children's hubs. And I think we've got to use whatever opportunities we can to build out that integration between Headspace and local KIMS services. Surge workforce is a point in time, but I do hope, and some of the feedback we've had from some of the kin services, again, workforce is a big issue. You've got great collaboration in some areas between the local tertiary service and headspace, and in other areas they don't know each other. They've had, so I think it's another interesting aspect of the reform is how we really facilitate that collaboration. How do we kind of get cross-sector working more? How do we get almost the health services out of the shadows a bit, because they've been completely under demand and under pressure, to try and drive more of that local kind of connection, and building up the broader platforms to hold those levels of acuity more in a community-based model of care.
I wonder if I can steal the mic. Just so our organisation runs a couple of headspace centres, and I know we have others in the room as well here who run some of the headspace centres in the eastern region. I suppose our experience has been not so much like we have a partnership, for example, at Headspace Hawthorn with Eastern Health. Eastern Health co-locate within Headspace. We have the Yeti program, which is I can't remember what it stands for, Youth Early Treatment. So it's sort of that tier 2.5 idea. But all of that is not much help unless you can have a pathway into the tertiary. So, and you can have all of the co-located, and it's fantastic having Eastern Health on our consortium at Hawthorn and co-locating there, and it's a really good partnership. But when there's a young person who needs tertiary services, if they can't be accepted into the tertiary system, I think what we're finding a lot, and I know there's others in the room that are the same, is that because the tertiary system is just at breaking point and overflowing, people end up falling down into the primary care system, and then we don't have the infrastructure and resourcing to support those people at such high levels of risk. So I know there's no easy solution to it, because I know that the reason we're not getting referrals into tertiary is because they're full. But the problem is that someone often comes through the front door into primary, and we assess their risk and their needs as needing tertiary, try and refer them into tertiary, and regardless of whether we have Eastern Health in the room with us or not, they're being bounced back. So that's really the challenge. And I know one of the things that Head to Help tried to do was have that sort of protocol with Eastern Health and with tertiary services to sort of have that pathway. And look, I know there's no way to have like guaranteed acceptance of referrals or anything magical like that, but it would be really good, I think, to have within this opportunity to reform the area services and the local services, to have a really almost like a separate door, so that if a local service is referring to the area service, it's treated differently to the other referrals. It's like, okay, this person, we know this person's had an assessment, we know this referral needs help. If they're telling us they need tertiary, they need tertiary. And that's just, I know it's not an easy sort of situation to solve, but that's certainly been our experience, that it's the inability to refer into tertiary that's causing a lot of the risk.
Yeah, and look, I think the all of that is ahead of us, because I think the vision, the intent, what success looks like in this space in a number of years' time is that that young person walking through a door, or through a local, or through an adult walking through a local, effectively, their care coordination and their care is primarily at that local level, at that community-based level. And they will have stages of support and services that are required at times they will need to access through the kind of tertiary levels. But effectively, and the Commission actually says this very clearly for adults, is that local services will act as the referral point. With the exception of kind of crisis response and emergency response, there's no other front door into a tertiary service but via a local. So that's actually, it's a design principle we have to engineer into the system. Now, for all the reasons you've just spelt out, Tasman, that's not just going to happen overnight. There's multiple components we've got to move in order to be able to do that. Least of which kind of, a single digital platform by which you can share, safely records, data. You can have a level of infrastructure that's capable of holding that level of acuity and providing that care you know, at that kind of beyond the kind of primary care into that kind of, I don't like using the term missing middle. You know, as someone keeps saying to me, they're not missing, nor are they middle. But that's that cohort that are just, yeah, not too unwell or complex to be held and supported at a primary healthcare platform, but not well enough to be accessing tertiary all their support needs in the tertiary service.
Yes,
so, yeah, I think will be lots of opportunities, particularly around the headspace. It'd be great to kind of work with a number of you in the sector in the coming year about, well, how do you drive that? What does that look like? And in terms of getting really integrated services.
Thank you. So the next one is probably a comment as well. So just again, talking about staff recruitment and workforce, that the requirement to have staff work after hours is making this more difficult for tertiary services. So that's an interesting comment, I suppose, with the focus on the area services providing more after hours services as well.
I'd like to understand that a bit more. Hard to respond to, you know.
Does anyone,
speak to that, or?
Does anyone want to speak to that one if they want to jump off mute? And
Sure. So I'm just aware that tertiary services are required to provide an extended time frame around provision. However, we know that a lot of staff are not attracted to jobs that require them to work shifts or after hours. And so that is a new challenge for the tertiary service provider to be able to recruit not only into roles, but also into these new kind of what are slightly higher level roles in the community, but then requiring, rather than a 9 to 5 response, an extended response. I don't know if others would like to add to that, like Lisa or Gavin.
I'm happy to add to it, Bronwyn. So I work for the Eastern Health Child and Youth Mental Health Service, Pam, and we have been trying for probably the last year to expand our access, which is our entry team, to provide after hours. And we started doing that just by expanding till 8 p.m. on a Monday night. And it's been incredibly difficult to attract staff who are wanting to do that. Our plan had been to hope to have it more than just one night, but we haven't been able to attract enough staff, and equally having real difficulties filling the surge funding positions as well currently.
And look, and I'm happy to just add to that one to Gavin Foster here. I mean, one of our issues, obviously, is we've got this older workforce. You know, we've got staff in their 50s and 60s and kind of starting to think about, you know, moving towards retirement. And so for many people, shift work is something that they'd like to leave behind. And so I think that's a bit of a challenge when that's a significant part of the workforce too. So I just think it's a real challenge we're actually facing around that, just in terms of the age of our workforce.
Yeah. Thanks, Gavin. Thanks, Melody. Those reflections.
So the next one is around AOD services. How do you view the integration of AOD services within the local services so that people can access a no wrong door treatment?
I think the who's probably asked the question would have a much deeper view of this than perhaps from my vantage point. I mean, I think what's one of the really exciting aspects of the Commission, the recommendations, is that integration piece around mental health and AOD. And I think we've got a real opportunity in front of us because it starts to bring some real structural intent to how we bring the service systems together. And I think there's a lot of opportunity in front of us, and we're gonna take small iterative steps in this space, and we'll work through with the locals around how we do trial that integration. We'll also do that with areas as well. This is kind of be a core component of what's expected for the area mental health services. So yeah, I think it's a really great and important opportunity, one which I think, you know, has been very positively received by the sector.
And certainly a number of people in the room today would have, you know, be very familiar with all of the VDDI work and all of the work that has been done over a number of years around trying to achieve that no wrong door. and also have probably attended a number of the AOD consultations with VADA and so forth around that. So there's been, yeah, I've been to a few of those. There's been some really interesting discussions, and
I might just add also on that. I mean, it's, you know, talk about the mental health and wellbeing division. We are the mental health and wellbeing and AOD division. That was just too long a title to give the division. But I think there's a real, can I just say it kind of, it's very pervasive, that conversation across teams about how we really leverage the reform opportunity for the AOD sector and with the AOD sector. So it's not kind of seen as a kind of, you know, second choice in terms of the reform efforts going into mental health. So not only have we got the, you know, very clear recommendations and signals from the Commission around integration of pathways and no wrong, you know, that kind of no wrong door treatment. I think we're also, you know, really purposefully and deliberately kind of interrogating the opportunities to really leverage the reform, and that's something that the Minister for Health's been really keen, and I think having had the mental health portfolio, yeah, he's really engaged in this conversation and what we can do.
So next question is, has there been talk about a marketing strategy for the general public, including culturally and linguistically diverse and healthcare providers?
Not that I'm not, maybe I can't really shed much light on that. There's some really, you know, I think there's kind of one recommendation that's focused around, you know, diversity of communities and how that's reflected in the reform, but it's actually quite pervasive in every recommendation in terms of how we make ensure services are accessible to diverse communities. And so I think there's a lot of good vision there and ambitious vision that we need to kind of work through, where my colleagues are working furiously to kind of start to stand up things like the diversity working group that was recommended by the Royal Commission. We're looking very closely at what data enhancers need to do so we can start to kind of build out much more enhanced data insights to really reflect the needs of the community and who the community, what the community needs and who's accessing services. So, yeah, happy to hear more thoughts if someone has them here who's ever asked that question.
Hi Pam, it was just me, Sarah. It was probably a thought that turned into a question, but the thought was just really around accessibility and I guess accessibility for, you know, minority populations and vulnerable communities. And I was just thinking about how I find myself, I mean, there's early days, I really understand that, but often I find myself going, I wonder what's happening and what's new and how is this all going to roll out? And I guess, you know, I always think about how do we get to our people and how do we get to our people who don't speak necessarily our English as a first language. So that was kind of what I was thinking about, but I think you answered it. It's probably early days and the recommendations are quite optimistic and ambitious about, you know, having those people as part of the rollout and the reform.
Yeah. Thank you.
Thanks.
I think if there's some learnings from the, you know, the Head to Help experience, it's probably that there are both some really good things about having like a single number entry point. So it's, you know, certainly living where we do, we sort of intersect across, not living, but, you know, working where we do, we intersect across so many different tertiary services that if you're trying to give somebody the tertiary psych triage number, you have to give them about 5 different numbers. So there's certainly something to be said about having, you know, one number for local services that diverts you based on where you live or whatever. But then on the flip side, there's also something, some interesting experiences we've had with Head to Help as well, where sometimes people are less likely to ring a central number because they don't know that service or they don't know who that is. So, you know, and again, that probably talks to that, you know, particularly the cold and Aboriginal community and where you want to have a lot of trust with the organisation. So there's a bit of a pros and cons, but I think everyone probably agree that having something that's easy to navigate and easy to access will be really important. Okay, so next question is, can you talk about the commissioning of integrated demo projects by the mental health and wellbeing boards in each area?
Well, probably only insofar as what's in the Commission's report. So part of that, you know, building out what is really a 5-year maturity model to devolve commissioning more at a regional level. So the kind of department will start to move into adopt over time a more strategic commissioning approach, and the vision of the commission is that the regional boards will be operating commissioners in their local areas. It's interesting that this was also reinforced by the Productivity Commission report last year as well. They also talked about both devolved governance and the need for co-commissioning across both jurisdictions. And I think the boards give us an opportunity to do that. We don't have any further details at this stage on that, but certainly the Commission's recommendation was that we start to do a couple of demonstration projects. And in some cases we have got that already. It's not new, this. I just want to recognise some of you on the sector and other parts of the department have been doing this. And we've also been doing it in some of our other programs like HOPE, for example. So yeah, no further new plans at this stage, but certainly they're on the horizon.
What role do you see this network, as in EMHSCA and others across Victoria, playing in the parts of the reform, or is it about connecting with the regional, or simply connecting with the regional boards?
Well, I think, and Tasman, I think the next question is probably related to that as well, around the how might EMHSCA align with the advisory functions. Look, I think one of the opportunities that we have is to understand what support these collaborative networks, where they exist, and how do we make sure that, you know, those connections and that collaboration is happening. I do think it was interesting. I had just by the risk of distraction, had a meeting this morning with Neurosciences Victoria. Some of you might be familiar with them. I mean, their model's been running now for 20 years, and it's a membership-based model and kind of collaboration across the kind of research community in Victoria. And I asked the question, you know, how do you drive collaboration? And they said to me, you need a driving force. And, you know, I do hope in time, and particularly in the first iteration of the advisory boards, these will become a driving force for collaboration, but they won't be the only driving force for collaboration. One of the things we're working on at the moment is, you know, we've got some really what we call early mover projects. And for each of those projects, whether it's been the Mental Health and Wellbeing Act, whether it's been the workforce strategy, we have kind of stood up time limited, either expert groups, roundtables, some statewide consultations for Engage Victoria. We've worked with both of our peaks as well, with Mental Health Victoria, VMIAC and Tandem, to really kind of maximise what engagement is possible in the timeframes we're working on those projects. But we're really keen to get to a much longer term position really quickly, to be able to provide as much certainty around what's the strategy, how are each of these recommendations going to be sequenced, what are the kind of core milestones and activities, because I think what that does, it enables the collaboration that is happening to connect and look for those opportunities for engagement with more foresight than what we've probably been able to do just in the short first 6 months since the reform work. So really critical. I think a lot of the work that groups like EMHSCA are doing is actually kind of the strength of the interim regional boards will be to leverage those existing collaborative networks and to leverage your local knowledge and expertise to guide their next steps, is to guide that kind of local needs assessments, planning, the collaboration. So I think for forums like this, and there's a couple of others across the state, it's really key in terms of working closely with the boards as they start to stand up. And I think, if you ask me that question in 12 months' time, there'll be an even better answer. I think this is also about how do we collectively forge this, where are the opportunities for all of us? The department won't have all the answers in this. It has to be driven from the ground up as well.
Excellent. And the last question then is there any thought of a system that can track an individual's mental health journey through the system for a better understanding of individual journeys or needs? I'm not sure if perhaps if the person who asked that question wants to expand on that. I'm not sure if they mean in terms of data or in terms of shared platforms or.
Yes, sorry, that was me, Jenny. Look, I don't really know what I, just from the perspective of, I guess, having some kind of central place that if an individual is engaged with this service or has been recently and is now engaged with this service, or would support collaboration perhaps, and maybe just sort of an overview of what's happening with that client, what they've tried, what hasn't worked, and could perhaps give us an idea of where to go next. I don't know. It's just an idea.
It's a great idea, and this was touched upon in a lot of the evidence that came to the commission, as I understand. People having to tell their story over and over again, that their journey is not so much a journey, but just these kind of ad hoc accesses to services they can access.
Sort of siloed.
That's right.
Yeah.
And this is where we have to do better in the future, don't we, if we're going to be successful. There's quite an ambitious reform agenda in the IT and data space, which will start to create the spine to connect all the various different tiers of the system. We're only just at the very beginning of that at the moment, and something that we need to do quickly, because it's going to be a foundation piece for the locals. How do they talk? How do they provide accessible journeys for people with the locals and the tertiary services? Our chief digital officer in the Department of Health has been tasked with this as his reform priority. So hopefully we can say a bit more about that in the future.
Oh, okay. All right. Wasn't a silly question then.
No, not at all.
I was a bit worried.
It's a great question.
So I think that was all the questions that came through on Slido. Does anyone else want to add or ask, or Pam, is there anything that you'd like to ask us?
Look, there's lots I'd like to ask you, but I suspect I do have to drop off. I've got a kind of 4 o'clock that the perils of working at home and jumping from Zoom meeting to Zoom meeting, as probably you all do as well. But just simply to say, look, I really do hope this has been helpful, and this has given you some, as you said, Tasman and Bronwyn, I get that feeling. I feel like every time I pick up the volumes of report, it's like a basket of eels. You think you've got a hold of it. Oh, there goes another recommendation that's connected to another recommendation. So hopefully I've helped you start to kind of understand how some of the component parts are coming together, what we've been focusing on in the department, and would love to find ways to come back and connect with this group. And kind of get your expertise rather than just listening to me. I think there's probably there's more I've got to learn from you than what you have from me at this point in time.
Yeah, Pam, we'd certainly would welcome you back anytime, and if there are certainly as things start to ramp up and when we know a little bit more about the Eastern Region services, we'd really love to be able to work with you and the team and collaborate together. So please feel free to reach out anytime.
Excellent. And, thank you. Well done on the collaboration. This is exactly what we're going to need to do to succeed in the future.
For sure. Excellent.
Right.
Well, thank you so much. We really appreciate your time.
No problems. Thank you, everyone.